Good afternoon, everyone. Thank you so much for joining us today. My name is Kayla Rogers, and I'm an Education and Outreach Coordinator for the Women's Fund. For those of you who are not familiar with the Women's Fund, we are a nonprofit here in Houston, and our mission is to provide women and girls with the tools they need to be advocates for their health. So we do this through focused seminars like today's presentation, as well as curriculum-based classes and publications. Our programs and publications are free. If you're ever interested in learning more, I encourage you to visit our website. I have the publication link and QR code here listed. We do have 4 fabulous publications that you can request physical copies of or download PDF versions of. So today we have our first presentation of Breast Cancer Awareness Series, and it is titled Breast Cancer Awareness and Treatment. And we are going to be hearing from Dr. Patel. So I'm going to go ahead and do a brief introduction before I turn the floor over. Dr. Patel is Chief of Hematology and Oncology at Kelsey-Seybold Clinic. He earned his medical degree at the University of California at Los Angeles and completed his residency in internal medicine at the University of California, Irvine in Orange, California. He completed fellowship training in hematology and medical oncology at UCLA Olive View Medical Center. Dr. Patel is board certified in internal medicine, medical oncology, and hematology. When he isn't caring for patients, he enjoys spending time with his wife and 2 daughters. So Dr. Patel, we're so thankful to have you here today and looking forward to this wonderful presentation. And I will go ahead and turn the floor over to you.
Thank you so much. I really appreciate the opportunity to speak to the group. It's been a little bit of time since I've done one of these with COVID and just being so busy in general. So it's kind of nice to get back into it. Will you be advancing the slides on for me?
Yes, I will advance the slides. You can just let me know when you want to move forward.
Okay, go ahead. Next slide, please. Okay, perfect. And I'll follow along on my computer. All right, so as everyone knows, this is Breast Cancer Awareness Month. And just to go over some background and some statistics, this should be no surprise to anyone in this group. After skin cancer, breast cancer is the most common cancer diagnosed in women in the United States. So thankfully, survival rates have increased very well over the last many years. Because of early detection and a combination of not only that, but also better treatments. So our survival rates have nicely increased. Patients are beating this cancer, surviving this cancer, or learning to live with this cancer for many years, if not decades, and if not lifelong. So that's very pleasant for us as oncologists to see, and of course, patients and family members. Likewise, the number of deaths or death rate associated with breast cancer is steadily declining. Again, combination of early detection and better treatments. Next slide, please. So awareness, again, October has traditionally been Breast Cancer Awareness Month. So next slide, please. So just a little bit about breast cancer and what actually happens. So by definition, cancer is unregulated cell growth. So another way to put it is breast cancer is occurring when breast cancer cells begin to grow abnormally. They're dividing rapidly. They're not dying naturally as they would. They form a mass, they form a clump, and then they grow, and that's called a tumor. So when they develop into a large size, we call it either a lump or a mass. Breast cancer cells start out in a few areas of the breast. The most common is called ductal carcinoma, which are the milk ducts that carry milk. So the cells that line those ducts are called ductal carcinoma cells. That's actually the most common kind of breast cancer. The second most common is lobular, which are the milk-producing lobules that produce the milk and then send it on to the ductal cells. Other than that, it can also grow in begin in glandular tissues in other cells, such as the fat cells or tissue next to the lobular and ductal cells, or the nipple areola complex as well. Turning to why breast cancer happens, it's a very complex question that, in my mind, is still not fully known. We know that hormonal factors play a role. We know lifestyle factors play a role, which we'll get to in a few slides. We know our environment makes a difference, such as diet and exposures. And then also there's some genetic background as well. We know probably about 10% of breast cancer is linked through genetic mutations that are passed from family member to family member. And by the way, it can be from mom's side or dad's side. So it's sometimes thought that it only occurs on mother's side of the genes, but no, it can be actually on both sides, on both parents. So those are some of the main reasons. Again, very complex interplay leading up to the formation of cancer. Next slide, please. So risk factors, we kind of touched about this briefly on the slide before. The top two risk factors, which neither one of us can control, are being female and increasing age. So women get breast cancer at a ratio of approximately 100 to 1-fold compared to men. So it's only about 1 in 100 as common in men compared to women. And then increasing age, of course, we don't control that. So breast cancer does steadily increase with age. At some point when patients are quite older, then there is a slight decline, but for the most part, there's a steady increase. Personal history, if someone's had non-invasive breast cancer diagnosis or a history of actual breast cancer, they do have a slightly increased risk of getting a new breast cancer in remaining breast tissue. So for example, that third bullet point on the left side of the slide, if you've had a biopsy that showed lobular carcinoma in situ, means it's just in the lobule, or ductal carcinoma in situ, meaning it's just in the duct, or atypical cells. That's what they refer by atypical hyperplasia. All of that gives rise to an increased risk of developing invasive breast cancer, as we call it. On the right side on the bullet points, the first one, breast cancer, we touched on that. If you've already had cancer in one breast, there is a slightly increased risk of developing in the other breast, or getting it on any remaining breast tissue. Thankfully, it's not a very significant risk unless someone has a genetic condition that predisposes them to a new cancer. But otherwise, for patients who don't have a genetic condition, it is just thankfully just a slightly increased risk. And then, of course, lastly is family history, which by nature is genetic. So if your first-degree relatives, such as your mom, your sister, diagnosed with breast cancer, particularly at a younger age, less than 50, that's changing, by the way. There's some subtypes of breast cancer where we even go up to age 60 and consider that genetic. All of that implies that the breast cancer could be genetic and that the risk is increased. But again, genes we think account for maybe about 10%, might be just slightly more than that, but the majority of breast cancer do not have family history or very, very distant family history. Next slide, please. Some other risk factors, inherited genes. We were just talking about this on the slide before. So years ago, scientists identified what's called the BRCA1 and the BRCA2 gene. Those are passed in what's called autosomal dominant fashion from parents to children. And again, it could be on both mom's side or dad's side. It doesn't mean one will get cancer for sure, but it greatly increases the risk of breast cancer. Some of the other cancers associated with these genes could be ovary cancer, pancreatic cancer, prostate cancer. So all of that will be looked at in family history when we evaluate patients. And in modern days, there's other genes that science has discovered, for example, ATM gene, and there's others that are not listed here. So nowadays in genetic testing, we'll do these large panels of genes that cover multiple genes. So as of real time, we're getting all the latest genetic mutations that are identified with breast cancer. Other risk factors, radiation. So what this means is, let's say someone had cancer in the past where they had radiation to the chest. So Hodgkin lymphoma is a great example where somebody can develop lymphoma in the chest and they got radiation directly here. So what's in the way? It's of course breast tissue. So then it raises the risk of breast cancer. In fact, those patients were supposed to screen at an early age with MRIs and mammograms. So radiation exposure is a risk. Obesity. Why is obesity a risk factor? Lots of complex reasons. One simple reason is that with obesity, we make more estrogen. So as the estrogen level rises, then estrogen tends to be a risk factor for many, but not all breast cancers. So that is a big reason. Early menstruation. So starting your cycles early or finishing your cycles late, i.e. late menopause, are also risk factors for breast cancer. Again, it has to do with chronic long-term exposure of estrogen. So if you start your cycles very early or have late menopause, you're just having more years of estrogen exposure. So that's what all the risk factors are. Next page, next slide, please. Other risk factors, delayed motherhood. So women who have children past the age of 30 do have an increased risk of breast cancer. Again, the thought process is that you have unopposed estrogen for all those years until your first pregnancy. Women who don't have pregnancy at all also have an increased risk. Same concept, you're getting estrogen exposure for many years. Hormone therapy. Again, what are hormones? Typically, it's estrogen based, so that extra estrogen can drive breast cancer in postmenopausal women. So in women who've already had menopause, ovaries have shut off, they take hormones for a few years. Very brief doesn't do it, but if you take it for a number of years, then the risk of breast cancer can increase. And then lastly, alcohol, drinking more than one equivalent drink per day has been shown to increase breast cancer. Some even list smoking in there as well. So those are some of the risk factors. Next slide, please. So how does one reduce their risk? So if you think of all the risk factors we mentioned, then if we can control some of those, then by definition, we're reducing risk. So for example, limiting alcohol. So limiting alcohol to less than one drink a day will naturally reduce the risk. Exercising and watching weight. So if you do aerobic exercise 30 minutes most days of the week, watch your weight, lower your body mass index. Will reduce your risk. And then of course, getting early screening, so early detection is very important. So getting your breast exams, self breast exam monthly, doing your annual breast exam with your physician, your OBGYN or your primary doctor, and of course, doing your screening mammograms are all very important in discovering breast cancer early. Next slide. Some other ways of reducing risk. So again, a lot of this touches on what we talked about with risk factors, and the opposite is what this slide shows. So if you limit hormonal therapy, so again, hormonal therapy is typically used in postmenopausal women. And typically it's given to control hot flashes, menopause symptoms. We do know that if patients take them for a number of years, then the risk of breast cancer increases. So we encourage patients not to take hormones or to use them very short duration if possible. And that's what the slide refers to, lowest dose in the shortest amount of time. Maintain healthy weight, we touched on that on the slide before. If you have a net weight loss or maintain good body mass index, typically the risk of breast cancer is lower. Eat healthy Mediterranean diet, fruits, vegetables based diet tends to have a lower risk of breast cancer, particularly the Mediterranean diet has been shown to reduce that risk. So that's something we encourage our patients to do as they're going through breast cancer diagnosis and treatment. Next slide. So what are some strategies we do for patients who are deemed high risk? So let me first touch on what is high risk. So high risk are patients who either have a genetic mutation. So let's say breast cancer runs in their family. They're known to have BRCA1 or 2 or one of these other genes that I mentioned. They'll come see oncologists or genetic counselors who will guide them on what is their exact risk of breast cancer compared to the average person and what can we do to lower that risk. So some of the strategies involved are to have preventive surgery, i.e. preventive mastectomy and reconstruction if the patient chooses to. If the gene predisposes to ovary cancer, often we'll have them do prophylactic removal of the ovaries at a certain age once they're done with childbearing and balancing menopause risk and all that. Gets into a complex discussion, but we do go over that with our patients. So that tends to reduce the risk of breast cancer. When you remove breast tissue, there's no tissue left to become cancer. So by nature, reducing the risk. It's not done very often. It's usually done in the patients who have a gene that raises the risk rate dramatically. For patients who have a increased risk, but not necessarily very dramatic. So for example, someone who has atypical cells on a breast biopsy, or they have what's called lobular carcinoma in situ, which are considered precancerous conditions, then we often talk to them about taking estrogen blocking or lowering medications. That's what the slide on the left shows. Because if you recall, we talked about estrogen being a driving force for breast cancer. So whatever pill you can take to lower that, then typically the patient will have a lower risk of breast cancer. So some of those medications, some of the names that you may hear are tamoxifen, Evista or raloxifene is the other name, aromasin, rexamestane are some of the other names. So keep those in mind. So those are some of the high risk strategies that we do. For patients who are high risk, we also tend to do breast MRI in addition to mammograms to further screen. The slide earlier that said screening, that's a way to screen early and catch new cancer very at a very early stage when it's much more treatable. Next slide, please. So when should you see a physician? So what are some of the symptoms? Of course, if you find a lump on your breast self-exam, immediately start seeing a doctor and get into getting in all the tests that you need, such as mammograms, ultrasounds, etc. The other change that you want to focus on is change in breast tissue. Even if you had a recent mammogram, you should still not ignore any changes that you see. Mammograms are good, but they're not 100%. Their sensitivity of detecting cancer is high, but it's not 100%. So we always want to balance both what we see on the exam, what the patient feels, and the mammogram. So what are some of the signs? Breast lump, of course, thickening of tissue or the skin that feels different than the surrounding tissue, change in size, shape, or appearance of the breast. So let's say there's a nodule that you already knew about, was thought to be benign, but changes, it shouldn't be ignored, it should be looked at. Changes to the skin over the breast, such as dimpling of the skin. So dimpling implies that the tissue is being pulled by a mass underneath the skin. Inverted nipple tends to be a risk factor. Again, something is pulling that tissue in. Usually it's a mass underneath the nipple. Then on the nipple areola, the areola is the dark tissue right around the nipple. If someone has peeling, scaling, crusting, flaking, nipple discharge, especially bloody nipple discharge, all of those are signs that something could be wrong and get checked. And then the last one on the slide, redness or pitting over the skin like an orange peel. That's a particularly worrisome sign for one particular type of breast cancer. It could be something else as well, but obviously don't ignore anything like that. So those are some of the symptoms to focus on and to seek care if that's occurring. Next slide. We'll talk a little bit about surgical treatment now. Next slide, please. So what are the common words that are used for surgical treatment? So lumpectomy is a common word that patients recognize. So lumpectomy is when you're removing a part of the breast tissue, a lump, for example. You're just removing the lump as opposed to the whole breast. Some of the older words used to be breast conserving surgery, partial mastectomy, or wide excision. Some of those older words tend to confuse folks. The best word to use is lumpectomy. And that's where the surgeon removes a small tissue that contains the tumor and surrounding skin to get negative margins. The rest of the breast is remaining intact. Cosmetically, if a patient has a lumpectomy instead of a mastectomy is when you remove the whole breast. Typically, reconstruction is not done unless there is a discrepancy in the visualization of the breast tissue. Sometimes after lumpectomy and breast cancer treatment, the breast can be smaller, firmer, sometimes scarring. So sometimes patients do need some reconstructive tissue with a breast plastic surgeon to balance. Next slide. Mastectomy. So mastectomy is another word that is often recognized with breast cancer treatment. So mastectomy is when, think of it as basically the whole breast was removed. So there's two kinds of mastectomy. The slide on the right is the more common, what's called modified radical mastectomy. That's when the entire breast tissue is removed, the lining of the chest muscle underneath, and the lymph nodes in the axilla, which are the ones in the armpit area. And that's the official breast cancer surgery where you're removing the tissue, removing the tumor, and testing the lymph nodes. Now, a simple mastectomy, the slide on the left, that's where the breast tissue is removed and some of the muscle lining, but nothing else. The lymph nodes are left intact, and many times the skin is left intact, what's called a skin-sparing mastectomy. Those are done in patients who don't have cancer, but are high risk. So let's say they have the gene that predisposes risk, selected after this risk reduction mastectomy. We don't remove lymph nodes in patients such as for prevention. We do for the patients who indeed have breast cancer. So those are the big key terms to remember: lumpectomy and mastectomy. Next slide, please. A little bit about chemotherapy treatment for breast cancer. Next slide. So chemotherapy implies drugs that kill cancer. So the vast majority are intravenous. Usually they'll go through a vein or through a special catheter on the chest called a portacath. depending on the type of chemotherapy. Chemotherapy on the first slide on the left is most commonly 3 to 6 months. There are a few that go on for 1 whole year. There's some particular types of breast cancer that require total treatment of 1 whole year. Definitely sounds like a lot, but thankfully not the entire 1 year tends to be as difficult as a shorter duration of time. Usually the 3 to 6 months is more your typical duration of time. And then there's a few other drugs that are given for the remaining time that are a little bit easier on the patient, thankfully. Most of these chemotherapies tend to be in cycles. Some of the cycles are every 3 weeks, every 2 weeks, every 1 week. And it all depends on the exact regimen, and that's determined by the type of breast cancer. There's a few subtypes based on estrogen marker, progesterone marker, what's called HER2 or HER2 marker. So the oncologist combines all that and determines your best treatment plan based on the specifics. And when we do that, that's what's called personalized therapy, where we're factoring in the specifics about one's breast cancer, confirming their treatment plan. A little bit about infusion therapy, the slide in the middle. Most of these chemotherapy drugs, as mentioned, go in through an IV setting, either in the arm, if safe, or through a central catheter if needed. Typically, it's 2 or 3 drugs at a time. Usually, it's preceded by nausea medicine, allergy prevention medicine, blood work. And afterwards, sometimes we'll do injections to keep the white blood cells elevated so they don't drop after chemotherapy and create infection. So that's all pretty standard nowadays with treatment with chemotherapy. The last slide on the right, chemotherapy sessions can be as short as 1 hour and as long as 6 hours, and that indeed definitely is the case. Most of them tend to be about 2 to 3 hours, but there are some that tend to be long. And like I just said, nausea medicines, labs, etc., are done first. Many patients will come often with a family member and just spend the time in the infusion suite, listening to music or reading or watching TV or just napping sometimes. That's a little bit about chemotherapy. Next slide, please. So radiation therapy, I'm not a radiation oncologist, I'm what's called a medical oncologist. So we're the ones who do chemotherapy. Radiation oncologists deliver what's called radiation therapy. So after surgery, the vast majority of patients who have a lumpectomy, again, a lumpectomy is when you're removing just the part of the tissue with the tumor in it, will have radiation to the breast. Radiation is a beam, an invisible beam that's delivered to that area, the regional lymph nodes, what's called the chest wall, depending on the type of surgery. It's done to kill any cells that could be left over. Now, mastectomy patients, when you remove the whole breast, even they sometimes need radiation, but it's much more commonly done with lumpectomy patients. Typically, if a patient is requiring chemotherapy and radiation, typically chemotherapy is given first. If not, then the next step is radiation afterwards. Next slide. So a little bit about radiation. Radiation is delivered by a machine. There's various machines out there. Varian is one of the common manufacturers. So radiation is by nature non-invasive. It's a beam. It's an invisible beam that's going to the breast tissue. There's different machines, different technologies. Some of the technology we have here at our clinic in Kelsey-Seybold is the Varian TrueBeam. It's a machine that tends to have a very narrow angle, very narrow beam, specifically contouring around the cancer to minimize exposure of radiation to surrounding regular normal tissue and specifically target the cancer cells. And some of the cool technology that they have on these radiation machines is called advanced imaging, where the machine tracks the patient's movement and will deliver radiation at the right time when they're in the right field. So when the patient moves and they're outside the field, the machine turns off, doesn't deliver radiation. When the patient comes back into the proper positioning, it delivers radiation. Breathing is a common use for this technology. So as we breathe, obviously our chest wall moves up and down, so the machine can track that for the right patient and follow along. And if they're outside the field, the machine turns off. When they're in the field, the machine turns on. Again, the point of all that is to reduce any damage to surrounding healthy tissue and deliver the beam to the tissue that needs it. It's called breath hold technique. It's usually done on the left side where the heart is to minimize heart damage. Next slide, please. Preventing damage, actually, we just talked about that. So the slide on the left, if it's left-sided breast cancer, then sometimes there's a little bit of radiation that can go to the heart because that's right behind the breast. So doing the radiation with the breathing techniques tends to separate the heart when you take a breath, and that's when the machine delivers the beam. And when the patient relaxes, then the heart comes closer and the machine turns off. So again, all we're doing is trying to minimize radiation to the heart and directed to the breast tissue where it's needed. Works quite well. Not everyone is a candidate for it. The radiation team determines that when they're evaluating the patient. Middle slide, surface guidance, is something similar, where the machine is tracking the patient's movement. So if they move outside the field, because again, you want the beam to be exactly where it's going and nowhere else. If they move outside the field, the machine will turn off. Patient moves back into the field, machine turns back on. And then constant monitoring is just another version of that. Again, if the patient's not in sync with the timing of the machine and the exact location, the machine won't deliver the radiation, minimize damage. So all these are new technologies and new tools that newer machines have. Thankfully, nowadays, many advanced centers in the country tend to have these newer machines, and including what we have here at Kelsey-Seybold are offering all of these. Next slide, please. Then there's another version of the Varian machine called the Edge. This one actually tends to be even tighter beams and angles. This is used for patients who have cancer, for example, in the lung or the brain, for example, or somewhere where it's very particularly necessary to deliver a very tight beam and avoid radiating any surrounding tissue. So this is just a little quick slide on this machine and its technology, and that's what the slide on the right refers to, superior targeting, again, to minimize any damage elsewhere. Next slide, please. That's the end. Okay, fantastic. Thank you so much. I really enjoyed this. Appreciate it. I hope I able to inform you of all the general aspects of breast cancer treatment, prevention, diagnosis, risk reduction. Certainly open for questions if they're out there.
Yes, thank you so much, Dr. Patel. That was a wonderful presentation. We're going to go ahead and open up the floor for questions. Since we're a smaller group today, if you would like to unmute yourself to ask your question, you can definitely do that. Or you can submit your questions in the chat box. I'm going to go ahead now and open the chat. So if you see a little box pop up on your screen, that's what that is. But I will kick us off with the first question. So you mentioned one of the things that we can do is perform breast exams at home. Do you have any tips for performing self-exams, and how often should we be doing that?
Yeah, that's a great question. You know, it's interesting how when I first started my training, it was always encouraged. And then there was a moment of time where it was discouraged. And then now it seems like it's come back in vogue. I personally would encourage my patients to do it all the time. And what I would tell the patient is, you need to get to know your body. So you know your body best. You know that that's a lump you've had your entire life. And guess what? This is a new one. So I tell patients, check once a month. Don't check daily, because that's when you'll miss something. Check once a month. And you go in a methodical manner where you cover the entire chest area, whether that's in circles from inside all the way outside. And then you also cover the lymph nodes on the side, which is right behind that tissue fold or the chest muscle fold, or whether you go up and down. It doesn't matter as long as you do it consistently and you do it on a regular basis. Usually once a month is good. In fact, I tell patients don't do it daily, otherwise you'll miss things. So again, either in circles going from the middle all the way out, or just up and down. Personally, when I'm with a patient examining them, I just go up and down. That's just what I've become used to. The point is to cover the entire surface.
Okay, thank you so much. The next question comes from the chat, and it says, what is thought to be the cause or causes of breast cancer in younger women, such as women in their 30s?
Yeah, it's a great question, and not so sure that there's a perfect answer for that. So I think we think it's a combination of genetics, but there's plenty of patients who have no family history, and when we test them, they have no genetic mutation, but some do. We think it's some combination of environment. And then frankly, it's a lot of unknowns. I think there's just still unknowns. Why are we seeing more and more young women? It certainly seems like it. The statistics seem to bear it out. We are seeing more young patients, particularly triple negative breast cancer is a type we tend to see in younger women. And I'm not quite sure science has figured out why we're seeing that. We think it's probably something in the environment. Maybe it's what's nowadays in our diet, or the way our lives are lived with stress. I'm not quite sure there's a great answer for that. Certainly, I don't have a great answer for that. Those are just observations and thoughts from from my knowledge and from my review of the literature out there, but I'm not quite sure anyone has a great answer, but we are indeed seeing it more in young patients. But I think the risk factors seem to be the same that we listed already. It's just very noticeable that we are seeing it in younger and younger patients these days. Great question.
Yes, that was a really good question. And I feel like you answered that the best way you possibly could. So thank you. We have another question in the chat. Someone is asking if you can describe a cancerous lump. So how can someone with thicker breast tissue tell the difference between fibrous tissue and a lump?
Yeah, another great question. It's actually hard, to be honest with you. Sometimes it's hard. So I'm assuming the question implies from a patient's perspective, someone who's doing a self-exam. So the key again is getting to know your anatomy. So when you do your monthly exams, what you want to look for is learn your anatomy, learn the lumps and bumps, learn what is normal and consistent for you. And when something changes, it increases in size, or there's a new lump that you're not used to, something different in the skin or nipple, all the things we talked about, don't think or assume it's fibrous, go get it checked. That's exactly how we hope and feel that we catch cancer early, but that is very tricky. Even for us physicians, it's very hard to tell sometimes the difference between fibrous tissue and a true lump. And that is why we'll end up doing mammograms and ultrasounds, et cetera, to sort that out. So it is tricky. That is not easy. I think the more you get to know your body and not ignore things is the key there. Tough question, but great question.
So the next question that I have for you, I know is probably something that you could spend a long time talking about. So if you want to just give kind of like a brief answer, but with diagnosing, how can you talk a little bit about staging and how women are diagnosed in different stages?
Mm-hmm. So staging implies determining the extent of cancer. So how big is it in the breast? First of all, is it invasive or not? If it's invasive, what's the size or how big is the mass in the breast? And then where has it spread? So has it spread to the lymph nodes, yes or no? Has it spread to other lymph nodes, for example, the ones by your collarbone? Or has it spread in the body somewhere, the lungs, the liver, the brain, etc.? So you use all those factors and you come up with a stage. And there's stage 0 that implies non-invasive breast cancer. So for example, DCIS or ductal carcinoma in situ, stage 0. Then there's stage 1, 2, 3, 4. And the variables between stage 1, 2, 3, 4 is size. The larger your size gets, the higher your stage. The more lymph nodes involved, the higher stage. And then if you have metastasis outside the breast and the lymph nodes, that's stage 4. So stage 1, 2, and 3 are in the breast and the lymph nodes. But again, the higher the stage implies it's a bigger tumor and there's lymph node involvement. So that's probably the simplest way to answer it. But maybe part of the question was, how do we determine that? So it's a combination of examination with our feeling, combination of ultrasound and mammogram, and sometimes MRI, and then sometimes a body scan to see what's going on in the body. You put all that together and you determine the stage. And the stage is needed to determine the ultimate treatment plan. So that's part of our role as an oncologist is we get a patient with a new diagnosis of breast cancer. We'll do whatever scans are left to do their staging. We'll come up with a final stage and then determine their treatment plan and then get going on that treatment plan methodically.
Okay, thank you. So I have another question here. So earlier, the question that we got about breast cancer in younger women, it just makes me want to ask, what can you tell us about what's in the works as far as maybe prevention or treatment, some things that are kind of still being, I guess, researched or worked on?
Yeah, that's a good question. There's always so much being looked at for treatment or prevention. In prevention, probably one big area is the enlarging role of genetics. So like I said, years ago, they only had the BRCA1 and 2 gene, and now they have these big panels that check for multiple genes, and that's constantly increasing. So genetics is rapidly increasing. Nowadays, we send these panels for young patients below the age of 45 or so, below the age of 50, sometimes below the age of 60. Even if they have no family history, we check it. So the role of genetics is really increasing in the early in seeing if someone's at risk for breast cancer. But to answer your question, as far as prevention, we'll tell the patient what we've been telling them all along. Watch your weight, exercise, eat right, avoid hormones, try and control the risk factors the best you can. And that's where it's at right now. I wish we had a great answer for younger patients. There's something different we need to do beyond what's already covered in the slide. We don't. That is the current status of the science right now. I think as we understand more and more about what's going on with younger patients with breast cancer, then eventually something new may come up. But as of now, it's really identifying family history. Am I at risk? Let me go get a genetic test. If so, then I'll start screening with mammograms and MRIs. If my family history is negative or I'm negative for genetic testing, then I'll focus on risk reduction with all the strategies that we covered on here.
Okay. Thank you. Another great question from the chat. After many years of mammograms, only last year did I learn I have dense breast tissue. Is this a question women should ask about?
Yeah, it's a great question. I think the answer is yes. So what's happened in mammogram technology in the last few years, newer technology has come out that lets the radiologist, the one reading the mammogram, get better looks through breast tissue, and breast density is being recognized more and more as something that does somewhat limit a radiologist's view of the mammogram. So newer machines, 3D or tomographic mammogram are some of the words that are used, have technology in them. It's the same mammogram from what my understanding is, but it just lets the radiologist have a better technology platform to look through the mammogram and decide if they see something that a regular mammogram might not have seen. So I do think it's important that patients ask, if I have dense tissue or dense breast tissue, should I get the 3D or tomographic mammogram? Should I be doing something different? Typically, that's what most radiologists and most health systems do, is have the patient go out and do a 3D or tomographic mammogram in that setting. The answer is yes, you should ask.
Great question there. So another question, you mentioned earlier that pregnancy has been, or having not been pregnant increases your risk. And I was curious, so if pregnancy is one of those things that can help with risk, does breastfeeding play a role in lowering risk at all?
Not that I'm aware of. So it's a good question, but no, not that I'm aware of that breastfeeding reduces or raises risk. I've not seen anything in all these years that indicate that. It's usually the items listed on the screen, for example, having your cycles very early or having menopause very late, or having children late or never having children. But I'm not aware of anything that says whether one breastfed or not raises or reduces the risk. So no, I don't believe it does.
Okay, I was just kind of curious. And then the final question that I have for you, if anyone else has any questions, definitely feel free to add those into the chat or unmute yourself. But the last question that I always like to ask is, if you could give us one final piece of advice or tell us the most important thing you'd want us to take away from this presentation today, what would that be?
Get your mammogram. You know, I see, even before COVID, I'd see that patients do mammograms, but sometimes they end up missing. Life gets in the way. People get busy. That's the reality of life. We all kind of put things off that aren't immediately necessary. So I'd encourage patients, stick to your schedule, get your mammograms on your regular time frame. Don't delay. COVID's added, unfortunately, an extra layer of difficulty with that. It seems to be settling down now, but it did last year particularly delay things. So don't delay your mammograms. I think that's key. Focus on the risk factors is the second key. Try and do what we mentioned about reducing your risk. But I'd say the main thing is get your mammograms. We see it. We see it as oncologists. Patients who get their mammograms, God forbid if they develop cancer, they're generally caught at an earlier stage when they're much more treatable and the cure rates are much higher. Generally, they need even less treatment, so it's less difficult on them. Whereas patients who don't get mammograms tend to come in with more advanced cancers, higher stage, as you were referring to, tend to need more treatment, longer treatment, so it's harder on them, and their survival rates are lower too. So I think the take-home message is get your screening.
That's a great message. Thank you so much.
Thank you. Really enjoyed it. Appreciate it. Thanks.
Yes, thank you for taking your time or taking time out of your day. We really appreciate this. If you do have any questions or comments afterwards, sometimes I walk away and I realize a day or two later, I should have asked this question. You can always email the Women's Fund at healtheducator@thewomensfund.org. I will be sending out a follow-up email with a survey link. We would love to hear from you, what you liked about the presentation, as well as other topics that you would be interested in hearing about. And next week, we wrap up our breast cancer awareness series with another presentation. And that one's going to be really good. So if you haven't registered for it yet, I highly encourage you to do so. I will be sending out emails with more information around that presentation as well. But I want to thank you all for taking time out of your day to join us. And I hope that you have a great rest of your day.
Thank you so much. Appreciate it. Take care.
Thank you. Bye.
Bye.